Hi, everyone. Thank you so much for joining us today. As we go through our second complex or busy ECG. So in our last session, we had a chance to have a look at an ECG that looked very busy and had a lot of things going on. And we looked at a system of how we could possibly break it down into smaller pieces and then get a chance to actually figure out what's going on. So today we're doing the same thing. Now, for those of you who joined I think it was last week, Wednesday, when we had the session, I posted the ECG that we would look at today, and I hope you'll had a chance to look at it. I know tomorrow is a public holiday in South Africa, so there's a lot of people who might be on holiday. So I don't foresee many participants in the live session. But if there are any of you who are in the live session, more than welcome to stop me, ask questions and things like that. So, without taking too much more time, we're going to get into it, and we're going to have a look at our second ECG. And if you did see the ECG prior to this, compare your answers to what we'll get to now in a second. So again, what we have here is an ECG that looks very difficult because there's a few things that are going on. It's not just a simple ECG. It's not just an ECG where you can easily pick out the patterns. There's a lot that seems to be happening, and it looks as though it's going to be overwhelming. And as I had mentioned the last time, this often causes people to shut down, not be able to look at it in an objective manner, and often run very quickly for help. Looking in the time that they're looking for help in interpreting the ECG, they're taking a few minutes just to break the ECG down into smaller bits. Could well have started helping the patient and then getting the relevant department involved, which really is our job in the emergency department. So here we have a 47-year-old woman with chest pressure and diaphoresis. So it's quite indicative of an infarct. There are differentials, of course, for chest pain and diaphoresis, but typically in an emergency department, that would be the first thing that we would think about. So an ECG would follow quite quickly. We'd want to do one, we'd want to check what's going on, and we'd want to try and take it from there. So you, as this young doctor now in the emergency department, you immediately go. You also see there's these odd readings on your SATS monitor. Your heart rate seems to be going fast and slow. You seem to be having an odd 3-lead ECG, and you do the 12-lead ECG, and this is what you pick up. And it looks very scary. I won't deny it. So let's look at what we need to do. So as I had mentioned the last time, the first thing is don't panic. Really don't panic. So what you need to do is you need to look at what you understand first, and then you need to break it down into simpler pieces. And you need to then, such as going through a system. This is why I always mention it's good to have a system of how you interpret an ECG. So generally, sorry about that. I think we just some feedback from somebody's yeah. Sorry about that. We just had some feedback from one of the participants. So I just muted them. Sorry about that. And to those of you who are just joining, you're more than welcome to stop me at any point and ask questions, and we'll go from there. So like I say, we're going to try and break this down. And then, like I say, what we're going to do is we're going to use a similar system to what we used in the last one, where we're going to look at what we understand and put that in a box, and then look at what we don't understand and then try and figure out what that may be. And then you decide on your next action. So let's go back to this. Let's go back to this ECG. And what we notice in this ECG, first of all, is that we've got these very large QRS complexes all over the place. And this is actually what is making this ECG look scary and making it look busy. So the first thing that we've got to do is that we've got to imagine the ECG without these. We've got to have a look at the ECG, looking at it from the point of view of what if those weren't there? Now they are there, but what if they weren't there? Now this is something that you can apply to a lot of your ECGs, but not necessarily all of them. But what I would suggest is if you see something like this, for example, now this wide QRS complex, this looks a bit closer to normal, but the rest of it looks quite off-putting. I'm not really sure what it is. I would suggest making a second or even a third reprint of the ECG, and either with a pen or with a mark or something, removing these wide QRS complexes from the ECG. Now that sounds easy, but it does take a bit of imagination on your part, and it does take a bit of time. But let's see what it looks like when we remove those things. So I'm going to do exactly what we did in the last one, and I've now made an ECG with those wide QRS complexes removed. Now, unfortunately, I couldn't get everything to line up because we do have some, it's quite an odd ECG. So there's a lot of areas where the lines just don't match up, but I tried to get it as close to a normal looking ECG as we could. So now let's analyze our ECG without the scary bits, without those wide, huge QRS complexes that we see. And let's just analyze it step by step, and let's take it from there. So the first thing that we do is we look at our axis. So if you look at lead one, it looks quite biphasic, but actually leaning more maybe towards the negative side, which means that electricity is moving away from lead one. And if we look at lead AVF, AVF is definitely positive. So let's draw that out. Just so that we've got it. Let's get a nice color over here. So we've got our axis here, all right? We've got our axis, we've got lead one, and we've got lead AVF, all right? And we said that the electrical axis was definitely moving away from lead one. So it's either in the right or the extreme right. And we said it's definitely moving positively towards lead AVF. So that leaves just one option, and that option is a right-sided axis. Now, of course, if this doesn't make sense to you, please go back, have a look at our basics of the ECG and how we determine the axis. There's a few ways to do it. This is just one way that I've taught you guys over the years. So having a left-sided axis means one of two things. Number one, either the left side is now enlarged and drawing more electricity, or number two, the right side is damaged, and because it cannot take on that electricity is shunted onto the left-hand side. Now, there are other reasons as well, but that's a basic way to think about it. So we're looking for pathology that's either causing destruction on the right-hand side, or that's causing an increase in the size of the left-hand side. Okay. So, and sometimes a combination of the two as well. Now let's look at our rhythm. So the first thing we look at in rhythm is our P waves. So as we can see, our P waves, they are a little bit peaked. All right. They're not necessarily abnormal, but they are a little bit peaked when we see them there, which may just indicate the atria are just trying a bit harder than normal, but it's not necessarily pathological in this case. You could argue that this is a pathological one, but I'm not going to get into that right now because in this case, it really wasn't, And if we look at our PR distance, in other words, the time from the atrium to the ventricle contracting, it was 1, 2, 3, just borderline. So it's 4 small blocks, which is about normal. As I told you guys, between 2 to 4 is generally considered normal. Less than 2 is abnormal. More than 4 is considered elongated. Then if we look at just our QRS complexes on their own, these QRS complexes are quite narrow. Okay. So the narrow QRS complexes, they're responding to the atrium. And if we look at them, they're quite regular as well, right? So this part of our ECG, without those wide QRS complexes, has a sinus rhythm. And if we look at the rate, we're looking at about 1, 2, 3, 4, 5. We're looking at just under 60 beats per minute. So it's a borderline bradycardia. So we know that we've got a sinus bradycardia. Okay. Now let's look at our zones. So we're going to look at the inferior zone, which is lead 2, 3, and AVF. Now, what's the first thing that you notice? Remember, we're discounting those QRS complexes. We're not worried about them at the moment. But the one thing that you notice is these ST elevations. And they're quite significant ST elevations as well. So if it's happening in the inferior zone, that means that we are having an inferior infarct. Okay, so just to revise it one more time, we'll just take it, sorry, let me just change this here. So let's get our little stick man, which I can't draw very well, but I'll try. All right. So let's just put our little stick man there with his arms and his legs. And then let's just put his heart over there. Okay, so there's his heart sitting in the middle over here. And if we remember correctly, then we've got our leads. So let's just put our inferior lead. So we've got lead 2, which is looking at the heart from this side, lead AVF, which is there, and lead 3. So all three of these are looking at the inferior part of the heart, leads 2, 3, and AVF. So we know that so far this looks like an inferior infarct. And if you remember what I told you guys the last time, if the ST elevation in lead 3 is higher than lead 2, it generally would tell us that there is a right-sided infarct as well. The one thing that we didn't get into is how do you confirm that? And the way that you confirm that is by doing a right-sided ECG. So let me just put some dots over here just so that you know. Let's put them in a nice color. Let's put green. So normally if you were setting them up on the chest, you would have V1, V2, V3, V4, V5, and V6, more or less like that. So all that you're going to do now is that you're going to move some of those over to the other side. So generally what we do is we move leads V3, V4, V5, and V6, or just V4, V5, and V6. So, or you can move all of them as well, but generally we'd move leads V3, V4, V5, and V6 to the right-hand side. And then if you see ST elevations in this new ECG, you know that you've got a right-sided infarct. And we've got a whole video about that. If you look through the playlist, you'll see where we discuss right-sided infarcts and what is called a 15-lead ECG. Okay, so that's basically what we're looking at now. All right. Now, let's look at two of our other leads that already come into play. So we're looking at, from our limb leads, we're looking at lead 1 and lead AVL. So remember, lead 1 is here, more or less, looking at the heart from that direction, and lead AVL is in that direction, all right? So they're kind of opposite to leads 2, 3, and AVF. So just in the simplified version, we can see that they both have ST depressions. So remember what we said, an ST depression, especially in the face of an ST elevation, is what we would call a reciprocal change. And a reciprocal change just means that because these three, which are at the bottom of the heart, are seeing ST elevations, we would expect those on the opposite side of the body to see ST depressions. That's a reciprocal change. So by seeing the reciprocal change, we can confirm that this is in fact a myocardial infarct. We can confirm that this is an inferior infarct, and we can confirm that this infarct is most likely spreading to the right-hand side as well. Okay, so I hope everybody understands that. I hope everybody's got that. For those of you who've joined late, please don't stress. We've just taken the whole ECG that we had. Let me just clear this out over here, sorry. So we've just taken our very scary looking ECG. I just want to go back a second for those who may have joined late. So we just took our very scary looking ECG with all of these wide QRS complexes, and then we simplified it by removing them completely, which is something you can do when you're working as well. And what we found is that we've got a left-sided axis using our methods, and then that we've got a sinus bradycardia based on the rhythm and the rate, and we started just looking at the zone. So that's where we are now. So this is using the system of taking what we know, putting it aside, making a diagnosis possibly from that, and then taking what we don't know and then deciding on that as well. So far what we figured out is that we have got an inferior infarct, and it's quite a serious infarct because the higher the ST elevations, the worse that the ischemia is. So this patient is already having a significant ischemia, and it's a right-sided ischemia. So if you figure that out, you can start treating the patient. Remember what I told you guys, if we've got a right-sided infarct, just stay away from TNT. That's the only thing. But, of course, you follow the protocols of your department as well. But generally, I don't think anybody would advise you to use TNT in a right-sided infarct. Okay. The only other limb lead that we needed to look at was lead AVR, which we can see here has got what you can just call a bit of a downsloping pattern. And this may also be due to the fact that it's on the right side of the body and looking at the inferior leads from the opposite end. I wouldn't call it an ST depression per se, but it's just a bit of a downslope. So let's go to our chest leads. So we've got leads V1 and V2, which are our septal leads. So let me just try and draw that out, just so that we just for revision purposes more than anything. So there's our chest in cross section, and let's put our heart in there again. So we've got our heart sitting like this. Again, sorry for the drawings. I know I'm not the best. And we've got our atria and ventricles. All right, so right atrium, right ventricle, left ventricle. And let's just put all of our leads over there. So we'll just dot them here. So we've got V1, V2, V3, V4, V5, and V6. All right. So V1 and V2 are looking at the septum, all right, which is mainly here. All right. And as you can see, they've got an ST depression that they've got over here. So that's further confirming our suspicion that this could be an inferior infarct. The other thing it could be is possibly a posterior infarct, because it's also looking at the posterior wall, but from the opposite side. So how would we confirm if it's a posterior infarct or not? It's actually quite easy, and it's something that everybody should know how to do. So it's a thing that, okay, I know it sounds a bit cruel, but years ago, in order to sometimes, just make the interns a bit flustered, is to ask them to go and get the 18-lead ECG machine and send them off into the hospital. And they would come back like half an hour, 45 minutes later, very heartbroken that nobody knows what the hell they're talking about. So an 18-lead ECG simply means that you take V4, V5, and V6 and place them along the back of the body. So this goes on the V4 now goes on the posterior axillary line. V6 becomes V9, and that's paraspinal. And then V8, which used to be V5, now becomes just below the scapula. So these now start looking at the posterior part of your heart. Now, like I said, I've got videos on this, so I'm not going to get too into it, but just so that you guys understand. So if we were suspecting that this could be a posterior infarct, that's what we would do. Okay. We see again in V3 and V4, we've also got ST depressions. We've also got very tall R waves over there. And the same with V5 and V6, where we see ST depressions. And we see also very tall R waves. So we could be leaning into the territory of left ventricular hypertrophy. So now that we've taken out the scary looking parts of the ECG, we already have a diagnosis. And in fact, it's very similar to our previous complex ECG that we had. In that one, we also found an inferior infarct with posterior extension, right-sided extension, and sinus bradycardia. And we've got a very similar thing here. So we've got an inferior, right-sided, possibly posterior infarct with sinus bradycardia as well. So it just goes to show you that even though these ECGs may be scary, once you actually start breaking them down into simpler bits, the diagnosis can become quite easy to pick out. And that's the reason why I chose these two, is because even though they look vastly different when you look at them in their entirety, when you actually break them down, you realize how simple they are. But I'll show you that in a little while. Okay, now before I move on, if anybody has any questions, please feel free to put it on the chat. Alternatively, you can just ask over the audio and I'll hear you as well. But I hope everybody understands how we've gotten to this point so far. So we've confirmed our patient has an MI, has a bradycardia. So let's go on from there. So now we're looking at the scary bits. All right, so the scary bits are these QRS complexes that we have. Sorry, these are a bit smushed out, but let's have a look at those. So these are the bits that we weren't concentrating on. So what's the first thing that we notice? The first thing that we notice is that, okay, these are deep, but they're also very wide. And generally, when we have a wide QRS complex, it implies that the ventricle is the one that's producing the stimulus. So the AV node or something further down, but they are the ones that are actually producing the stimulus for the contraction. Now, as we had seen in the previous one as well, this could be a form of the heart trying to increase its own rate. So these may be escape beats or ectopic beats, or they may be premature ventricular contractions, whatever you call them. That's not the issue. The issue is that the heart itself is trying to improve its own heart rate to keep up its output and to be able to make sure that it receives enough blood in the diastolic phase. Okay. So this is all that it was. As scary as it may have looked here, these are literally, that's all that it is. It's just a premature ventricular contraction. It's just the ventricle contracting on its own before it should, without any input from the outside. So by breaking this ECG down into very small parts, we can actually see how easy it is to get to an answer, right? So there's one specific thing that I just wanted to speak about in relation to these, because we'll get into that in a second. So let's just have a look. So we have a sinus bradycardia, a ventricular rate of 100, frequent premature ventricular contraction in the pattern of ventricular bigeminy. Please don't stress about that for now. That's something we will learn about. An acute inferior MI, all right? So the sinus rate was 50 beats per minute, as we have said. Additional P waves may be obscured by the PVCs. It does happen. But from what we could see from the intrinsic waves, we do have an ST elevation in the inferior leads, an ST segment depression in the anteroseptal leads, which is downsloping, and these leads do not have prominent R waves. So this is getting into a very technical thing about how you differentiate between posterior and inferior plus posterior. So don't stress about that. At your level, that's something we sort of concentrate on as we get more senior. All right. So this patient was treated with beta blockers for the ectopy and underwent a successful PCI. Now, there's one interesting thing, and this is a little bit more advanced, but it's something nice for you to see because it's something that people often miss. Now, I'm not stressing too much about everything that's written over here, but I just want you to concentrate on this little piece of information. It's called R on T. All right. So an R on T, which is what we see here, is basically when you look at the T wave, you can see that before the T wave is completed, you now have another contraction that's going on. So this was slightly different from the previous ECG, which we had seen. So in other words, as the heart is relaxing, it starts to contract again. And as I remember talking about it in a previous video as well, previous session as well, that this is similar to you tripping over your own feet. So what happens is that if you trip over your own feet, there's always a possibility that you're going to stumble and fall. And with the heart, that can happen. So basically what this entire diagram is trying to express is that should you continue to get these R waves on the T waves, there's a possibility that the heart will stumble. So that fall that you take, those few steps that you take after you stumble over your own feet are essentially a tachycardia. So this is a tachycardia that continues, all right? And it can be quite significant. So your patient can end up having significant ventricular dysrhythmias. They can even go into cardiac arrest and things like that. Now, the reason why I mention this is because even in the last one, we had realized that we needed to prepare for a bradycardia. In this case, we need to prepare for a tachycardia. We need to be able to get this patient's PVCs basically away from the normal QRS complexes. That's what they achieved with the beta blockers. And should the patient go into a full-on arrhythmia, full-on ventricular tachycardia, we'd have to deal with it from there. Okay. So in this case, the patient went into a pulseless ventricular tachycardia, which is a shockable rhythm. All right. So it's just an interesting thing to know. It's a nice thing to talk about, like when you're on ward rounds and things like that. You'll sound very clever if you understand this little thing. All right. So R and T. Yes, by all means, you can ask a question. I see Dr. Momo has the hand up. Please, you can ask a question.
Alarms. I
Yes,
just wanted to know, this R on T wave, is that like a precipitating event that we can look out for before the patient goes into a VTAC?
that's exactly what I'm saying. That's exactly what I'm
Okay.
saying. So it
All
definitely
right.
can precipitate a VTAC, and it can precipitate a pulseless VTAC or a pulsatile VTAC. So
Okay.
like I say, watch the previous video where we actually were worried more about bradycardias, but in this one, we're more worried about a tachycardia. So these R1T phenomenons are not only seen in ischemia, they're seen in a lot of different situations, but the best way to remember it is when you see your T wave and then you see a QRS complex starting more or less before the T wave has completed. That's the easiest way to remember it. That's how an R on T is described. And like I say, it's like the heart is stumbling over itself. But unlike you who would stumble on your feet and eventually fall, the heart doesn't have that luxury. It just keeps on stumbling and stumbling and stumbling and stumbling. And so our job is to try and stop the stumble. So there's two ways that you stop the stumbling. Number one, you take the feet and you drag them apart, which is what a lot of the drugs do, like amiodarone and beta blockers. So what they do is they increase the time between the the relaxation and the contraction. So if somebody was stumbling and you pull their feet apart, the chances are is that they would start to walk normally. The other thing that you would do if somebody was stumbling is that you would catch them and stop them in the hope that when they started walking again, they would walk correctly. And that's what defibrillation does. Defibrillation stops the heart. So the reason why I'm putting it in these simple terms is so that it makes sense in a real world example. So I hope you guys understand what I'm trying to say, and hopefully it will make it easier for you going forward. Now, of course, when you're on your rounds and discussing this with others, uh, please don't tell them that I'm defibrillating to catch the person who's stumbling on their feet. They look at you like you are crazy. All right, but just as long as you have the idea in your mind of why you're doing it, or you understand the example, it's like, why are you giving amiodarone? I'm pulling the feet apart. You're going to sound uh, rather weird. So please don't do that. And just to have the image in your mind of what we are trying to do. Okay, so I just wanted to show you guys our last two busy ECGs, as I like to call them. All right. So you can see if you look at the two, if you had these two ECGs on two patients right next to one another, they look very scary. They really do, because there's a lot going on. There's a lot going on. In the end, we came out to almost the exact diagnosis on both patients. This was an inferior posterior MI with PVCs. This was an inferior MI with PVCs. The only difference was this had also this R on T phenomenon, which you can see here. So just to revise, the best thing that you can do when you have one of these busy ECGs, like I say, print out another one, even a third one if you need to. Remove the parts that are looking strange, or remove the things that you don't you it just doesn't make sense to you. What is this? Now, of course, it won't apply to every ECG. Some of them are very obscure, but in a lot of them you can, for example, remove wide QRS complexes. You can remove, for example, if you have three abnormal beats suddenly in the middle of nowhere, you can just remove those and then go through your ECG as normal. And you'll often find that you come to a reasonable diagnosis of what's going on. And the thing that looks abnormal, it doesn't mean that you should know the answer to it, but at least you can make an educated guess. For example, if you were to say to a senior, listen, we've got an inferior MI and it looks as though the patient is having abnormal ventricular contractions, which is not really a term that's used, but your senior will understand what you are trying to say. And at least the fact that you made the diagnosis would assist as well. So I hope that makes sense to everybody. Um, like I say, the R1T is a nice thing to know for ward rounds. If you do see it, it will make you look very intelligent. As I always say, even if you know nothing else in medicine, if you know ECGs, people think you're very clever, and I'm a living example of that. All right, I know nothing else, but I know ECGs, so everybody thinks I'm very, very clever. So just before we complete, I just want to know if there were any other questions as well. So Dr. Mo, the question you asked was a very good one, and I really appreciate that. It's something to think about. So like I say, in the last one, in this one, we are worried that should we continue to have an infarct, we may eventually end up with a problem where we have um, a bradycardia, and in this one we have the possibility of stumbling into a tachycardia. So that's about the only thing that you would have to consider. But working in an emergency department, should one of those things happen, you have to be prepared for them. The truth is that this can also become a bradycardia. It can, because should the patient be unable to produce this ventricular beat, they would now start going into more of a bradycardia um, as the infarction grows. And this patient also has the possibility of going into a tachycardia should the body decide it wants to put in more ectopic beats. And then there's always a possibility of it also getting an R on T. So even though we prepare ourselves, in reality, we never know what's going to happen. So I hope you guys understood that. I hope it makes sense. And I hope you've learned at least one method of how to handle these busy ECGs. And like you see, the reason why I decided to do these two was because of the ECGs that I was receiving to, comment on. And I realized people are just shutting down without really looking at the ECG. So I hope you won't be a doctor who does that. This is just a little joke to finish off. But in any case, if there are any questions, now is the time. And if you have understood what's going on, please, you can let me know as well. So hopefully we will cover more ECGs in the weeks to come, and we will learn more about different conditions and different ECGs that we see in the emergency department. The next session that we're going to have on Wednesday, we're actually going to discuss a blood gas, and we're going to go through a blood gas and discover we'll go through the basics of blood gas interpretation, but also just looking at a particular case of a blood gas. So that's what I'm hoping to do on Wednesday. I'm not sure if anybody has any questions or if everybody understands what's going on. It will always be beneficial to go back and watch this at another point. Should you joined late or didn't understand something. And like I say, I'm always available for questions that people have. So if you have any questions, feel free to message me if you are on the groups. If you're not on the groups, just comment on the YouTube video, and then I'll try and answer from there. Even corrections today, I received a correction for a video I'd done quite some time ago, and it was true. I did make a mistake during the video, so it's good to have interaction with people. So if you guys can let me know in the chat if you guys are okay with everything, then we can end the session for today. Or alternatively, if you have any questions. I'm just trying to make sure that it's not silent. That's why I'm just rambling on. So if everybody is okay with everything, then you can just let me know. And yeah, okay. Don't see any questions coming up. So can I take it then that everybody was happy and everybody understood what was going on, and that hopefully we'll have another good ECG. I've got a nice one lined up for next week, but like I say, on Wednesday this week we'll cover a blood gas and we look at blood gas interpretation. So I hope to see you guys all there, and yeah, thanks so much for joining me today. I really appreciate it. Like I say, I know it was it's a public holiday tomorrow. A lot of people are on leave and things like that. So I really do appreciate it. And I hope you guys have a good day off if you're not working tomorrow. And if you are working tomorrow, I hope it's not too bad. But thanks everybody. I really appreciate it. And this, sorry, somebody in the chat. No, thanks a lot, Dormo, as well. I appreciate that. And yeah, so yeah, hopefully see you guys again soon. And